Welcome to the Boston Medical Library's 48th Annual Garland Lecture, The Framingham Heart Study at Age 75, Forever Altering the Face of Cardiovascular Care. I'm Rick Peters, President of the Boston Medical Library. This is our first in-person lecture presentation since the pandemic, and our first as guests of the UMass Chan Medical School Lamar Suter Library. It's being presented virtually as well, with closed captioning for the hearing impaired, and will be posted on our website, bml.org, by next week. This posting will include the question and answer session after the talks. And I would ask the Zoom audience to please use the question and answer function to enter your questions as we go along. In February 2022, the BML entered into a new partnership with the UMass Chan Medical School to provide library services and lifelong learning opportunities for physicians and dentists in Massachusetts. Please visit our website, bml.org, and please consider becoming a fellow of the BML. The Garland Lecture is named in memory of Dr. Joseph Garland, the 13th president of the Boston Medical Library and the former editor of the New England Journal of Medicine. The Garland Lecture has been one of the proud traditions of the BML since 1976. I want to express my gratitude to the members of the Garland Lecture Committee for their role in planning this lecture, and mention especially Dr. Bill Mackey of Tufts, who was actively involved in this work when he passed away suddenly in January. Tonight, you will hear from two distinguished academic physicians who have been leaders in the fight against heart disease. Our first speaker will be Dr. Deeb Salem, a national expert in coronary artery disease and congestive heart failure, who has been a longtime member of the Tufts medical faculty. He was appointed professor and chief of cardiology in 1987. He served as the Sheldon M. Wolf Professor and chairman of the Department of Medicine and physician-in-chief at Tufts for over 20 years. He's currently the senior vice president for academic integration for Tufts. He's been a leader in numerous professional organizations, including president of the New England Cardiovascular Society and founding president of the New England affiliate of the American Heart Association. He has served on the boards of many organizations, including the executive board of the Board of Trustees of Tufts Medical Center, the Northeast affiliate of the American Heart Association, and the Massachusetts Hospital Association. He's been the recipient of many awards from both academic and medical institutions, including the American Heart Association, the Massachusetts Physicians Health Service, and the Massachusetts Medical Society. In May 2021, Dr. Salem received the coveted Tufts University School of Medicine Dean's Medal in recognition of extraordinary service. Our second speaker is Dr. Daniel Levy, director of the Framingham Heart Study, chief of the Population Sciences branch of the National Heart, Lung, and Blood Institute, and professor of medicine, Boston University Chobanian and Avedisian School of Medicine. His main areas of research include epidemiology and applied multidimensional omics data to the study of hypertension, heart disease, and heart failure. As one of the founders of an international genetics consortium, he has led genome-wide association studies that have identified many of the known genes associated with hypertension. He leads the Systems Approach to Biomarker Research in Cardiovascular Disease Initiative, which seeks to integrate big data from thousands of Framingham Heart Study participants with recent genetics to identify causal genes, proteins, and pathways contributing to cardiovascular disease. He's received many awards for his research from the National Institute of Health and the American Heart Association for his work in epidemiology. Dr. Levy authored an acclaimed book about the revolution in our understanding of the causes of heart disease, titled A Change of Heart, and he has served as editor-in-chief of 2 medical journals. He's also served on multiple U.S. guideline committees for hypertension and cholesterol treatment. Dr. Salem?
Thank you. This is the first time I've ever given a lecture sitting down. And what I will be doing, since the slides are not within my ability to see that far, excuse me for turning pages while I'm looking at the slides. This is a fantastic opportunity for me because I've reunited with Dan. Dan and I we've known each other for years, and to talk about one of the most important things in the history of cardiovascular disease in the world is an absolute pleasure for me. Okay, now I'll hopefully when I push this, the slides will turn. Which button do I push? I turned off the slides. Okay. Is it this one?
No, it's this one.
Okay. Thank you. So this is probably, to me, the most interesting part of what I will discuss, and that's the federal President Franklin Delano Roosevelt, who in 1945 was noted to have severe hypertension. I even found a number that said his blood pressure went to 300. I'm not sure how accurate that was, but he died from this, and that created a sensation and concern in the medical community and in the then President Truman, who signed the National Heart Act that established the National Heart Institute and the Public Health Service. Actually, I worked at the Public Health Service years ago. And thus was born this study, the multi-generational, decades-long study to people's health in Framingham. $500,000 was assigned to a 20-year epidemiologic study of, quote, heart disease. Starting in 1948, the Framingham study produced revolutionary findings that we'll hear about tonight. And the study was supervised by the then called National Health Institute, which now is, as you know, is the National Heart, Lung, and Blood Institute. Oh, I'm so sorry. Okay. The initial Framingham heart study was associated with Boston University, which was my alma mater in medical school. Probably the question that most people ask, and I've been asked about it for a long time and didn't really know the answer till I prepared for this talk, was why was Framingham chosen? Framingham there were several reasons, both Dan and I had similar slides until we converged regarding this. Framingham successfully conducted the Framingham tuberculosis demonstration study years before. The proximity to Boston became important, and cardiologists in Boston were very interested in having the study performed nearby. And on top of that, Framingham physicians felt it would be a wonderful thing to have the study start there. And the Department of Health, and on top of it, Harvard Medical School, which was very influential, was important in this. So I had the honor of meeting Dr. Paul Dudley White, who was at the Mass General Hospital for many, many years. And he and Dr. David Rothstein at Harvard Medical School advocated for the study to be located in Framingham, Mass. And at that time, Framingham had a population of 28,000 residents, and people felt for the 1940s at least, Framingham represented the population of the United States. I'm not sure how accurate that was, but I think that that was one of the reasons. Going forward, the National Health Service delegated Dr. Meadows to develop an epidemiologic study. And he, I think, was the person that put together the whole business of studying the heart. And this is a quote from him. He wanted to, quote, to study the expression of coronary artery disease in a normal or unselected population and to determine the factors predisposing to the development of disease through clinical and laboratory exam and long-term follow-up. Kind of a revolutionary, amazing thing that, you know, somebody would think of. And then you say, why didn't somebody think of this before? The budget request, which was very interesting at the beginning, was for $94,000 to cover supplies and even included funds to buy ashtrays for the smoking needs of the study staff members. I'm old enough to remember, the students here will like gasp at this. And in my days in medical school, it was not unusual to sit in a room and a lecture and people are smoking in there. And now, you know, you old enough to remember that? No. Okay. Well, I do. And I remember, you know, almost coughing at these lectures, especially when they were surrounded by people smoking pipes. This, don't try to read the small print. I just took a picture of this, but this is an amazing letter that came to Dr. Meadows. And basically it said, after looking at what he was doing, the town of Framingham felt it would be wonderful to have the study there, and Harvard Medical School at the beginning was providing him with space. And so that got the study launched. He moved to the Boston area to become the first director. And at that time, he recruited 6,000 Framingham residents. Imagine that. You're trying to knock on the doors of 6,000 people and say, we want to just examine you and follow you for the rest of your life. It's an amazing feat. And he was operating out of Harvard at that time. In 1948, the Framingham Heart Study examined its own staff in order to test the schedule, equipment, and techniques of the study. I don't know if the students, you know, in those days, it was not unusual to say, see one, do one, and teach one. So they practiced on each other how to approach things and before they went to the patients. The study design was, you know, started in really 1948. It gives a date of October 11th. 5,209 healthy volunteers aged 28 to 62 were the original recruited cohort, and that cohort was gotten bigger and bigger through 1952. Here's an important thing that you may not realize the importance right now. Oh, they decided to have half the people in the study women. Throughout my career, we've seen studies, I've seen lots of studies that did not include women, and the foresight to be sure that they had an even population of men and women, I think made the study even more valuable. What did they obtain at the beginning? They got family medical history, physical exams, 12 lead EKGs, and blood and urine sample. And that was it. And that was the beginning of following people with those physical exams, blood pressure readings, et cetera, over time and seeing what they could figure out. As time went on, the other things were thrown in terms of what was measured. The EKGs quickly contributed to the detection of coronary heart disease and left ventricular hypertrophy. Just think, nobody really had EKGs of people before they had their MIs and then when they had their MIs. Initial coronary heart disease studies included the next cholesterol measures, blood pressure measures, smoking, and obesity. Okay. New diagnostic studies as time went on were included. Probably if I had to talk about the revolution in caring of heart patients in my career, it would be echocardiography. That changed everything, except for one little comment I'll make. Echocardiography has decreased the ability of younger physicians to do good physical exams of the heart. We'll just get an echo. Don't do that. Learn to examine the patient better because that's the only negative I have about echocardiography. Carotid artery ultrasound, magnetic resonance, computed tomography, and Holter EKG monitoring were next in line or in line. And this led, and probably the most important thing I'll say at this point, this led to something that Dan really was one of the inventors of, coronary artery disease risk factors. We always, we look at people and patients and we want to know what their risk factors are, and that helps us judge how to approach them. So this is a very busy slide, and don't bother looking at too much of it. On the right side of the chart, look at the percentage of women as time goes by that were in the study. 55%, 53%, 58, 9. So it was actually a little more women than men, which really made this interesting study. And then as time went on, they started looking at diversity. They wanted to include African Americans, Hispanics, Pacific Islanders, and that, believe it or not, took a little more time than you would have expected, but it ended up probably in the 90s becoming a big part of the study. The first major findings of the Framingham Heart Study were published in 1957. This one, you'll fall off the chair when you're here. When I was in medical school, people described how you talked about normal blood pressure, what blood pressure, what your normal blood pressure was was 100 plus your age. So guess what? If you were 60 years old, it's all right to have a blood pressure of 160. I have not dug. I should, maybe in the library, we should dig in how that number ever got there. So those were doctors being trained that, oh, your blood pressure is 150, you're okay until you drop dead. So over time, one of the biggest contributions was figuring out what was blood pressure, what were the blood pressures that really you had to worry about. So this chart is talking about blood pressure as it relates to developing a coronary disease. And you can look at, no pointer, I don't think, but if you look at the left side, as in per age, the higher your blood pressure, the more likely you develop coronary disease. Sounds kind of, everybody knows that. No, nobody knew that then. The other thing is, there was an era where people talked about how important diastolic blood pressure is, and it's not all that important. It didn't track the same way as systolic blood pressure readings, and that actually there was, I even remember arguments about that that issue. These, but this is these sort of oval charts, not a pie chart. Note that hypertension was also a dominant factor, and Dan published this, determinant of heart failure. Well, in my career, I've done a lot of work in heart failure, and hypertension, just like it was an important factor in developing coronary disease, it also is an important factor in developing heart failure. Here, the discussion is not heart failure, but end diastolic diameter. End diastolic diameter itself was found to be a predictor of developing heart failure. And I was one of the principal investigators in a very important heart failure study called SOLVE, which, I think was part of its development was findings from the Framingham Heart Study. And the SOLVE study, which we finished in 1990, one of the things we looked at, besides symptomatic patients with heart failure, that asymptomatic patients that had no symptoms whatsoever, but had large hearts and decreased ejection fractions. And we found that that the diastolic pressures were very important in terms of the future of patients, and in terms of dying from heart disease. This is something I was thinking not of talking about, but I found it so interesting, I decided to talk about it. And this was something that came out of the Framingham Heart Study called the 7 Countries Study. And it was an epidemiologic study that brought in other countries. Instead of the USA, just us, it was Finland, Netherlands, Italy, Croatia, Serbia, and Japan. How these countries were chosen. Actually, when I was reading, I found there was some dispute of why these countries were chosen. And there was a physician that Dan told me about the other day, named Ansel Keys, and really was the study that figured out what Paul Dudley White, whose picture is on this slide, this study that verified what he had talked about for years, that diet had something to do with developing heart disease. And believe it or not, that was controversial in those days, but the Mediterranean diet was discovered. The people on diets that we now call the Mediterranean diet was discovered to be a factor in not developing coronary disease, and that came out of the Framingham Heart Study. So here is a list of, it's kind of amazing. It's like the Emmys of the findings of the Framingham Heart Study. The discovery of hypertension, coronary disease, heart failure, atrial fibrillation, neurologic outcomes of stroke, the risk factors for these, and ultimately the diagnosis, subclinical and clinical vascular disease, findings regarding cardiac imaging, biomarkers, and you'll hear from Dan about genetics and genomics. And the one that's in dark print, say there's 10 on the slide. The one that doesn't make the slide, but was one of Rick's and my favorite things, do your heart a favor, take a vacation. Men who did not take a vacation were 30% more likely to have a heart attack. So everybody take a vacation. So I'm going to conclude with Henry Tulgin, who I've worked with at the Mass Medical Society, gave me this. Apparently he went to medical school in Albany and New York State. I was raised in Brooklyn. So New York State tried to do a study like the Framingham Heart Study. It didn't really work too well. It lasted from 1953 to 1981, and I'm not sure it added to something. And it just thinking how the Framingham Heart Study was so powerful, and really people that tried to do it had a great deal of difficulty. The last two slides I will say is, in many lectures I've given, there was a providential thing would happen, meaning as I'm ready to finish the talk, I read something that was brand new, and I tell you to check the October 17th JAMA, and the study that was just published there, effects of the Million Hearts model on myocardial infarction, stroke, and Medicare spending. Basically, they took the risk factors that the Framingham Heart Study had discovered and said, let's pay money to make sure that people looked at these risk factors compared to doctors that just treated people the normal way, whether they looked and didn't, and they found a significant difference in survival of the patients that where the risk factors were paid attention to at no greater cost, although money was spent to get this done. And I'll move more quickly. I'll just end with this thing. Before I made the talk, I looked at my own bibliography, and I saw that there were 14 publications that just one little old cardiologist had done that used Framingham data. And so just think of the thousands of cardiologists that are in academic medicine that owe a lot of what they did to the Framingham data. So I'm going to turn this over to Dan, but I'm going to tell a story. Yesterday was Halloween, right? I almost was going to buy Dan a costume to come in dressed as a chauffeur. Now, why was I going to do this to Dan? Well, many years ago, I had the pleasure of meeting Dr. Christian Barnard, who did the first heart transplant. And the story goes, it's apocryphal, but the story goes that after he did the first heart transplant that succeeded, he and his chauffeur went all over the world giving lectures. And one day his chauffeur turned around and said to him, I've heard that damn lecture so many times, I think I could give it. And so Dr. Barnard said, okay, I'll put on the chauffeur uniform and you give the lecture. So he gave the story goes, he gave a perfect lecture. One of the world's most famous heart surgeons was there, Dr. Michael DeBakey. And Dr. DeBakey asked this very complicated question. And the poor chauffeur then suddenly turned around and said, I'm not going to dignify this question by answering it. I'll have my chauffeur answer it. And so if you have questions here, I'll have my chauffeur answer them. And so thank you so much.
Oh, here we go. Oh, Deeb, it's great to be here with you and to spend time again together. I'd like to thank the medical library for the honor of inviting me here today. I'll follow up on some of the foundational materials that Deeb presented, talking about how Framingham, now celebrating its 75th anniversary, helped unravel some of the mysteries of heart disease. The slide's not advancing. Thank you. If we go back to the beginning of the 20th century, we can see that the leading causes of death were all infectious diseases: pneumonia, influenza, tuberculosis, infectious diarrhea. And at that point in time, the average life expectancy for a baby born in our country was about 50 years. If we fast forward to today, the leading causes of death are heart disease, cancer, and chronic lung disease, all chronic diseases, non-infectious. And the average life expectancy for a baby born in our country is about 80 years. In other words, over the course of only about 1 century, we've increased the lifespan of the average baby born in our country by 50%. That's a remarkable story. This transition, we call it an epidemiologic transition from infectious diseases to chronic non-infectious diseases, really changed the way we approach treatment and patients. And again, heart disease, from being nowhere among the top causes of death to becoming the leading cause of death, at some point there was a transition point. And as Deeb mentioned, it really occurred on April 12th, 1945, when President Roosevelt died. Now, his press secretary denied that he had any health-related issues. But here's a picture of Roosevelt surrounded by Churchill and Stalin in February of 1945. And at that time, Roosevelt's blood pressure was 260 over 150. And this was at a point in time at the end of fighting in Europe, when these leaders were there to carve up the map of Europe and make critical decisions about the future. Roosevelt was in dire straits at that point in time and would die just 2 months later. His last recorded blood pressure was 300 over 190. He died of a massive stroke, a cerebral hemorrhage. And as Deeb mentioned, that his successor was Truman. The head of Truman's Office of Scientific Research and Development was a brilliant engineer from MIT by the name of Vannevar Bush. And Bush said, "Much illness remains for which adequate means of prevention and care are not yet known." He went on to say, "Any extension of medical facilities must be accompanied by an expanded program of medical training and research." In other words, we have to fund an understanding of the causes of the diseases that are afflicting people in our society. And it really was in that setting that the Framingham Heart Study began in 1948. As Deeb mentioned, it began with the enrollment of 5,209 originally healthy men and women, and they were put through extensive evaluations: medical history, physical exam, laboratory test, chest x-ray, electrocardiogram. They were brought back every 2 years. There have been over 30 cycles of exams on these originally healthy people, and it was through those exams that many of the so-called risk factors for heart disease were diagnosed. The only thing is, there are no longer any surviving members of that original cohort. Just last month, the last surviving original member, over 100 years old, passed away. So this is one of the few medical studies anywhere in the world that followed a population literally to extinction in order to understand the causes of the diseases that occurred in that population. When the study began, the study investigators lacked the computational tools. This is a picture of, on the left, what the IBM computer cards looked like. Anyone ever see an IBM punch card? And you would punch information depending on the row and column. There might be a little click you would place on it to indicate someone had high blood pressure, or another click somewhere else, someone had diabetes, another click somewhere else, depending on another feature. So I think it was 80 columns and 40 rows on that card. And that was the only information that you could collect. And the cards were punched using the machine on the right, and they were sorted. You had a stack of 5,209 cards put through a card sorter if you wanted to identify everyone in the population who had diabetes. You want to find everyone with diabetes and hypertension to understand what happened to them, you'd have to go through a second sort on a second field on that card. And it was that type of approach that was used for early publications from Framingham. Again, no computers existed for the study to reach any of its conclusions. I was very fortunate. Two of the early mentors in my career were Bill Cannell and Joe Stokes back in the mid to late 1980s. And they were among three of the authors of one of the very most important publications of the entire 20th century in the field of cardiovascular research. And that was a paper called Factors of Risk in the Development of Coronary Heart Disease. Bill Cannell was the first author of that paper. He was then a young researcher at the Framingham Heart Study. And I've gone back and reread this paper a number of times. It's beautifully written, and I'll just share a few quotes. Years of follow-up experience in the longitudinal prospective study of coronary disease in Framingham have confirmed the influence of hypertension and hypercholesterolemia in the development of coronary heart disease. It is now demonstrated that these factors precede the development of overt CHD in humans and are associated with increased risk of the development of CHD. There can be no doubt that absence of these characteristics is distinctly advantageous, since such persons demonstrate a relatively low risk of developing coronary heart disease. And very importantly, he went on to say, whether or not the correction of these abnormalities, once they're discovered, will favorably alter the risk of development of disease, while reasonable to contemplate and perhaps attempt, remains to be demonstrated. In other words, what he was saying was, even though we have identified these factors of risk, we need to do clinical trials of intervention against these factors to modify them to determine if doing so can reduce a patient's risk of disease. Bill's term factors of risk was eventually turned around to become risk factors, again, part of common medical and lay parlance today. Well, among the people who read this paper from Bill Cannell and Roy Dauber and Joe Stokes was Ed Fries, who was the head of the VA hypertension program in Washington, D.C. I had a pleasure of interviewing Ed Fries for a book that I wrote, and he was the first author and lead of the VA cooperative trial of blood pressure treatment. This was the first randomized controlled clinical trial of hypertension treatment that was ever conducted. And by today's standards, it was alarming. It was a study of only 143 people who had moderate to severe hypertension, diastolic blood pressures of 115 to 129. Why wasn't it also a study of systolic pressure? Because no one thought systolic pressure was important back then. And I mentioned it was the best possible science. It was double-blinded, placebo-controlled. And active therapy included 3 drugs that everyone received in the active treatment group: hydrochlorothiazide, reserpine, and hydralazine. Active therapy lowered blood pressure on average by 43 millimeters systolic and 30 millimeters diastolic. The study was terminated after just a year and a half of intervention. And Ed Fries told me he was scared to death to publish these results because he was afraid people would attack him for leaving patients on placebo therapy at those levels of blood pressure. Well, you didn't have to be a statistician to interpret the results of that trial. On the left are the number of cardiovascular events that occurred in those receiving placebo, and on the right, events in those receiving active therapy. Accelerated hypertension, 12 versus 0. Stroke, 4 versus 1. Coronary events, heart failure, renal damage, deaths, all occurred exclusively in the placebo-treated patients. In other words, active treatment to lower blood pressure had dramatic effects on multiple hypertension-related outcomes. A few years later, in 1971, the Framingham Heart Study enrolled a second generation of study participants. This was 5,124 children and spouses of children of the original study participants. This offspring study was focused on the familial basis of cardiovascular disease, and as Deeb mentioned, it involved the introduction of cardiac technologies such as echocardiography, ambulatory electrocardiography, and treadmill stress testing. At the end of the 20th century, the Washington Post published a study, a paper, an article describing what they considered to be the 100 most important medical advances of the 20th century. At the very top of that list, not surprisingly, was the introduction of antibiotics. Recall, as I mentioned, the most common causes of death at the beginning of that century were all infectious diseases. Number 2 on the list of most important medical advances was mass immunizations or vaccines. And of course, today, following the pandemic and the important contributions of COVID-19 vaccinations, we can very much appreciate that even to this day. Number 3 on that list was the discovery of vitamins and new approaches to nutrition. And number 4 out of the top 100 medical advances of the entire 20th century was the Framingham Heart Study. Very shortly after that report in the Washington Post, there was a celebration of completion of the draft sequence of the human genome in June of 2000. And here you had President Clinton surrounded by 2 people. And I wonder if anyone knows who either of the 2 people that was there to celebrate with Clinton were. Well, on the right side is Francis Collins, who went on to become head of the National Institutes of Health. Back then, he was head of the Genome Institute. And on the left side was Craig Venter, who was the head of a private venture that was competing with NIH to sequence the human genome. And it was a bit of a bitter rivalry. And Clinton, in his wisdom, declared victory and ceasefire. And that kind of, those 3 people in the same space reminded me of that famous scene from Yalta. Anyway, back at that point in time, Francis Collins proclaimed, "I would be willing to make a prediction that within 10 years we'll have the potential of offering any of you the opportunity to find out what particular genetic conditions you may be at increased risk for based upon the discovery of genes involved in common illnesses like diabetes, hypertension, heart disease, and so on." I thought that was a very bold and dangerous prediction. I thought it would be impossible to fulfill that dream. Well, it was shortly after the completion of the draft sequence. I should add that the cost for the original genome that was sequenced back then was close to $200 million for one genome. Today, by the way, we've sequenced the genomes of over 7,000 Framingham Heart Study participants. In the year 2002, we began the recruitment of a 3rd generation of Framingham Heart Study participants. These were the grandchildren of the original participants, the children of the offspring cohort. And this was another 4,095 people. Much of the focus with our third generation was genetics. We've done genome-wide association studies, exon sequencing, whole exome sequencing, whole genome sequencing on thousands of our study participants. I had the privilege of leading one of the very first studies of whole genome analysis to identify the first common variant genes responsible for blood pressure elevation. And in this paper that came out in 2009, we identified about 8 genes harboring variants that were common and associated with variation in blood pressure and occurrence of hypertension. A few years later, we'd increased the sample size for these genome-wide association studies to over 1 million people. I had the privilege of being involved in an international collaboration, and we had raised the number of genes involved in blood pressure regulation to over 500. We've now just completed a more updated study with over 2 million people with genome-wide association analysis, and I can tell you that the number of genes involved in blood pressure regulation is over 2,000 today. Quite remarkable. A few years later, in 2009, President Obama announced $5 billion in NIH funding. And he went on to say that since 1948, researchers have been following generations of residents in the town of Framingham, Massachusetts, and how the town of Framingham has contributed importantly to our understanding of factors involved in the occurrence of coronary disease, and how DNA from these participants was advancing our understanding of the genetic causes of these diseases. In other words, we had, within those 10 years, largely fulfilled Francis Collins' dream that we would soon be able to predict who would go on to develop hypertension. And President Obama was announcing that money would be going to increase our ability to understand genetic causes of disease. And some of those funds went on to fund a program that I was involved in called the SABRE CVD Initiative, the Systems Approach to Biomarker Research in Cardiovascular Disease, that sought to identify biomarker signatures of atherosclerotic cardiovascular disease and its risk factors using cutting-edge omics, genetics and genomics, metabolomics and proteomics, microRNAs, and a little bit later DNA methylation analysis to help us understand genetic variants, genes, proteins, and pathways involved in disease, with the belief that doing so would help unravel approaches to treatment and prevention. This is the logo of the Framingham Heart Study, and you can kind of see what looks like a helix representing our DNA, but there are 3 coils here representing the 3 generations of our study participants. And it began in 1948 as a population study of large numbers, thousands of individuals, eventually expanded to 3 generations of participants. We've gone from the level of the population down to the genetic variation in our DNA and the mysteries included in our DNA that help us understand the genetic basis of disease. We not only are measuring individuals' DNA, but we've frozen here for a moment. We've gone to the level of our RNA, the genes in our DNA encode for RNA, and we are measuring the RNA and its expression in our study participants as well. And those DNA and RNA genes encode proteins, and those proteins act upon small molecules or metabolites, and we've measured those also in our population. We're applying sophisticated analytical approaches such as systems biology to unite the information from clinical risk factors, from our DNA, from our RNA, from our proteins and metabolites to understand molecular mechanisms of disease, with the hope that this knowledge will unravel new approaches to advance the cause of precision medicine. And you might wonder, is this all a fishing expedition? This is me in Plymouth Harbor catching some striped bass. And I think the answer is yes, it's a fishing expedition, but using these approaches of proteomics and metabolomics, we are catching lots and lots of fish. And the fish that we're catching are helping us understand the mechanisms of disease. Over the course of now 75 years of history of the Framingham Heart Study, we have learned an enormous amount of risk factors for heart disease, and we're today extending that knowledge into the genetic and genomic basis of heart disease to open up new areas of opportunity for treatment and for prevention. Over the course of just the last 50 years, we've seen dramatic reductions in deaths from heart disease and stroke by 60 to 70%, representing the savings of hundreds of thousands of lives each and every year in our country. Analysts who've looked at the contributing factors to this momentous decline in death rates from cardiovascular disease have concluded that there's about a 50-50 contribution to that decline to improvements in treatment and to improvements in prevention. And in that regard, I'd like to think that all the work that we've done at the Framingham Heart Study, elucidating factors of risk for heart disease, whether it's the original factors of risk like elevated cholesterol and blood pressure and diabetes and obesity, and cigarette smoking, or extending into today's insights into the many genes involved in causing the risk factors themselves that open up new avenues of treatment to prevent or treat disease. It's been a great privilege for me to be part of this study, and I hope we have many more years of discovery and success. Thank you very much.
All right, thank you both. I'm going to remain a disembodied voice to our Zoom audience, but I'm going to read out some questions from our online Q&A. We'll do that for a bit, and then we're probably going to end the Zoom, and everyone who's here in person, if you want to join us in the Lamar Suter Library, we have some snacks and we can keep discussing. So I'm going to prioritize the online questions and read them out loud for you both. Our first question is, the mortality data are outdated by many years. Currently, the third leading cause of death in the US is COVID-19 and the fourth is accidents. So I guess that was more of a comment on your earlier mention. Someone also had a note that in the Yalta photo, the only leader holding a cigarette was FDR. Another question is, does the FHS plan to enroll another generation of subjects? And if so, when do you anticipate that would be?
Yeah, we've had discussions about potentially enrolling a fourth generation of study participants, extending our work to young adults, adolescents, and children. And we can't just say we'd like to do it. We have to put forth a very compelling reason to do so. And as Deeb mentioned, when the study began in 1948, it was largely a European ancestry white population. We've more recently enrolled from the minority ranks within the community. We have sister studies, though, for example, the Jackson Heart Study of African Americans. We have the HCHS Soul Study, the study of Latinos that involves over 14,000 people of Hispanic ancestry. There would have to be a very good reason, a compelling reason to do it. And I believe today, were we to do so, we'd have to partner with other studies and ensure that there was far greater diversity. I should add, by the way, in that picture of Yalta, Roosevelt was having a lot of difficulty, episodes of shortness of breath, which turn out to be congestive heart failure. And he was examined by Churchill's personal physician, Lord Moran, who said, commented in his memoir about how desperately ill FDR was and called him one of the sickest people he'd ever examined who was still alive.
A follow-up to the question about a new generation of the study is, do you have an idea of what a potential focus would be?
Yeah, if we were to do a fourth generation, I think much of the focus would be on primordial risk, or the emergence, the earliest emergence of risk factors, things like blood pressure that was within the normal range, but slightly higher among some individuals than others. We'd be looking at things like lipid levels and some additional lipid risk factors like Lp(a), and to what extent those are trackable down to childhood and adolescence. By the way, among all the risk factors that we know, the one that is more heritable than any other is Lp(a).
Yeah. Okay, I'm glad you mentioned that, because I've just given a talk about Lp(a), and the reason why it hasn't been chased down was that it was very difficult. It's very difficult to treat. I've had one or two patients that would tolerated niacin at doses that make most of us like turn purple. But I'm told, I was just told the other day, that at least one of the drugs that lowers Lp(a) will be released. I don't know why they're waiting at 2025. So I think once we know, but I totally agree that it's an amazingly strong risk factor, and I bet most of us don't measure it enough. But we published something about it using some Framingham data, in the 1970s, I believe.
So this is a bit of a longer introduction to this question, so forgive me. So the question is, at 75 years, the FHS predates coronary angiography. Given that over 75 years, not only does standard of care change several times, but also definitions. Given those changes, you have pointed to examples where definitional changes were applied to past data retrospectively to change standards of care. Can you comment on whether you believe that these evaluations are more robust than more traditional double-blind, placebo-controlled, forwardly directed studies common today in changing medical care?
Wow. That was quite a complicated question. I'll talk about the highest standard we have, the highest standard that the FDA considers is a double-blind, placebo-controlled randomized trial. And observational data are useful in suggesting the importance of a factor, but demonstrating a benefit of treating that factor using a randomized placebo-controlled trial is the highest form of science we have available. Now, there is one additional new tool that we have in genetic epidemiology that is changing our ability to identify potentially valuable treatments. And that's something we call Mendelian randomization, a rather fancy term, allowing us to use genetic causal inference to identify a factor that is causally related and distinguish it from a factor that is simply associated with outcome. And I'll give you a great example, two examples. One is HDL cholesterol. Drug companies spent billions of dollars developing drugs to lower HDL cholesterol, with the belief, based in part on observational data from Framingham, that HDL cholesterol was a risk factor. Therefore, it must be important for us to try to raise the HDL cholesterol. Pfizer developed a drug called torcetrapib, spent hundreds of millions of dollars on a clinical trial to try to prove that raising HDL cholesterol would be beneficial. The drug was phenomenally effective raising HDL cholesterol, but it had no effect whatsoever on reducing coronary disease risk. It turns out this could have been predicted by applying a genetic technique called Mendelian randomization to infer from genetic data that raising HDL would not be beneficial in terms of lowering heart disease risk.
I almost thought I saw that it made things worse.
It made some things slightly worse.
I'll give you my favorite example of a risk of a association, and it's a diagonal earlobe crease. So that one, I don't think having a diagonal crease in your ear really does anything, but it's actually related to having a higher incidence of coronary disease.
Yeah, another example, by the way, is C-reactive protein, very powerful indicator of inflammation. And you would think that targeting the gene that encodes C-reactive protein to lower C-reactive protein levels would be beneficial. But it turns out that Mendelian randomization to infer a genetically caused low C-reactive protein turns out it would not be beneficial to target C-reactive protein. There are other genes, and we've learned very much so from a number of clinical trials, that targeting inflammation can be beneficial for heart disease prevention, but targeting C-reactive protein itself would not be beneficial.
Another question is if you can comment on the impact of exercise and diet in preventing heart disease.
I'm sorry.
Exercise and diet.
Oh, well, I'm a big believer in both of them. And I think there is evidence that, but at least, you know, steps, counting steps, it turns out that moderate exercise is actually as good, if not better, than, you know, meaning one of the most interesting studies I saw a few months ago is you think of marathon runners as ones that having the least chance of developing coronary disease. And it's been said that, but it turns out a group of people that were sub-marathon runners had a better survival than the ones that were marathon runners. So maybe the whole thing, everything in moderation, including moderation, is important. You know, diet clearly is important. It's sort of not as important, perhaps, maybe now that we have drugs like statins that sort of help, and maybe the combination of the two, but certainly I will say that statins have been proven to be pretty good in terms of we've done bypass surgery now for years and years. Once statins came around, the amount of redo bypass surgeries, at least we've seen, crashed, and that's how effective they are. The little scary thing now is the discussion that the statins do increase blood sugar, so there's another interplay with that. But
Another question is white coat, that's in quotes, hypertension significant?
Yeah, so there's a continuous and graded relationship of blood pressure to risk. And most people who have white coat hypertension tend to have high normal blood pressure. And in the setting of seeing a physician or a nurse practitioner or physician's assistant, their blood pressure goes up because of that anxiety. So it's a false positive hypertension due to the vision of a white coat. It results in a misclassification, can result in unnecessary treatment, which is why we recommend things like home blood pressure monitoring so we can do a better job matching the intensity of blood pressure treatment to a patient's actual level of blood pressure. You mentioned, Deeb, this old adage of having a blood pressure of 100 plus your age. When I first started the Framingham Heart Study in the mid-1980s, I would go over to the local Framingham Medical Library. And shortly after I started, they had a sale of used medical books. And I bought a book that I found, which was the first edition of Paul Dudley White's textbook of cardiology. And I bought it for $3. It's probably worth quite a bit of money today. It was in mint condition. And in that book, he talks about the myth of a blood pressure of 100 plus your age. And he said that a normal blood pressure is probably really a systolic of 120 or a diastolic of 80.
Wow. So when they have blood pressure, one of the things that I've learned is that a lot of what we have as solid data about blood pressure measuring comes from very careful studies, the technique that's used to get it. And most of the time, when we take care of patients in a clinic, we don't measure it the same way as the studies had measured it. And always scratch my head. Maybe we should be teaching more that at least when we get the blood pressures on patients to use the same style of getting it, putting your feet down flat, you have all the way that the trials have done. Maybe we'd be matching things a little better. Have you ever thought of that?
Yeah, very much so. And I think in some of the most careful blood pressure studies, they had people sitting quietly for 5 minutes before someone comes into the room to measure their blood pressure. And in a busy office practice where the patient just walks through the door and sits down and gets blood pressure measured, you may not be making the best possible assessment of blood pressure. And again, I do think that home blood pressure recordings and keeping a diary of those recordings is very important to avoid unnecessarily aggressive treatment in some patients.
And I don't use it very often, but there is also sort of the whole Holter monitor of blood pressure. You can actually hook somebody up. We get it through our nephrologist that you can get blood pressures taken over a whole day. And sometimes that's very helpful in terms of figuring out when to give medicines, et cetera. But that's something that's, I think, is underused.
I think we're getting to the point of wrapping up. So I'm going to invite Rick up and I'm going to mute myself.
We have time for one question from the floor, if there's anybody who has a question. And we'll be in the library afterwards. Mario?
What's that?
Can we send the results of this?
Well, what I'd like to send to Florida.
Get close to the mic.
Oh, I'm sorry.
The question was, can we send the results to Florida?
But I'd like to send, I might get myself in trouble, but I haven't done that for a few days. I'd like to send to Florida a message that don't put a stent to every patient that I have that goes to Florida.
I thought you were going to make a political statement.
Yes.
Integrating pollution as a risk factor, because we know from the big cities like Delhi that some heart attack, we know there is a risk factor.
So the question is, do you have any plans to integrate pollution into the Framingham Heart Study?
Yeah, so it turns out we have been collaborating with a number of people who've been studying air pollution. And there are monitors all over the state. And we know where each of those monitors is. We know where each of our participants lives. We can approximate the particulate matter in the air next to each of our study participants, and have a number of projects working with Murray Middleman at Harvard and others looking at particulate matter in the air, the PM 2.5 or particulate matter of 2.5, I guess it's angstroms in size or something like that. And whether we can connect that to participants' risk of heart disease. And it is an active area of research in Framingham, and many other studies have started to look at the particulate matter and air pollution.
Thank you. I think I want to, on behalf of the Boston Medical Library, thank you both, Dr. Levy and Dr. Salem, and thank you all for attending. Those who are in attendance, we invite you to come to a reception in the library, which is out the door to the left and that way. Please come. Thank you very much.